Welcome back to you, Year 5 medical students, meeting back on another topic of toxicology. Today I will be talking about carbon monoxide poisoning. Monoxide is an odorless, tasteless, and colorless gas formed by hydrocarbon combustion, especially the incomplete combustion. The concentration in the atmosphere is quite variable, could be 1 part in 1,000, and could be higher in some urban or some polluted areas. Carbon monoxide binds to hemoglobin and its affinity is greater than oxygen, forming carboxyhemoglobin, and this one would impair both oxygen transport and utilization. Carbon monoxide also precipitates some certain inflammatory reactions inside the nervous system through lipid peroxidation, ending up with some kind of delayed neurological sequelae, just like those we mentioned in the past during lectures of organophosphate. Epidemiology. Fire-related smoke inhalation is responsible for most cases of carbon monoxide poisoning. And the number of intentional poisoning with carbon monoxide unexpectedly is as twice as those with accidental one. It means that some certain intention be behind that, whether it's a homicide or suicidal one. The annual death in the United States approaches 500. Accidental poisoning demonstrates some kind of seasonal and regional variation. It happens mostly in winter seasons and picking up in January. And definitely regional variations include those areas where there are cold weather, and in addition to that they might probably use certain kind of heating system that would be not convenient, especially in the household heating manner. Other potential sources of carbon monoxide would be fire, including improperly ventilated fuel burning devices like kerosene heaters. We have this problem common in our country, and we faced it in the past, and we'll be seeing it every year happening in our patients who present to the casualty department. Electric generators, those in the past, like during the 10 or 15 years ago, generators were in every house, and they were using their local generators to supply kind of electricity. And not uncommonly we face having those patients presenting with exposure to carbon monoxide and poisoning in certain situations were very serious. Motor vehicles, when they operated in closed spaces like garage, is making a lot of CO and kills people, definitely. Unfortunately, in our area, the housing system and the kind of the design of the houses, they like to have a garage that opens into the house, and this would be a bad one. We every now and then hear about stories like couple being spending a night and while the engine was on and they were in the garage, found dead in the morning. And this is a common story all the time in this country. Unfortunately, it leads to some drastic and kind of gloomy ends, death of youth in this situation. The incidence shows two peaks. It's more common in those under 14 years old and those between 20 and 40 years old. Well, the incidence is not much variable, it's not different between both sexes, but the mortality is much more among men and increases with increasing age. A few months ago we heard about a family dead in Hawler and Kawa, and they probably had that as an accidental source of carbon monoxide came up from the heater, from the kerosene heater they had at home. Unluckily, 3 of the family members died. And they were IDPs coming up from Mosul. Pathophysiology. Carbon monoxide is an odorless and tasteless gas. You can't sense it, you don't know it's around you. Just might cause sudden illness and even death without knowing that it's around you. Because it diffuses very rapidly across across the pulmonary membrane or the diffusion membrane, it goes to the blood very quick and combines to the heme part of hemoglobin in a greater affinity than those of oxygen. Hundreds of times is having more avid to the combination with hemoglobin. It also combines to the other globins or other heme containing compounds like myoglobin inside the cytochrome. But the one with hemoglobin impairs oxygen transfer in the way that once it binds to one oxygen binding sites of the hemoglobin, which are four, in fact, one combination makes the other three unable to have oxygen offloading capacity because it undergoes some kind of structural abnormalities. So this would end in leftward deviation of oxygen dissociation curve. By binding of carbon monoxide to myoglobin and the cytochrome, there would be impairment of oxidative phosphorylation. In the common pathway that you remember from biochemistry, the oxygen transfer chain, which happens inside the mitochondria, this one would be impaired to a great deal. And the clinical implication would be very frank on the heart, where the mitochondrial dysfunction would be due to CO poisoning, causes myocardial stunning in spite of adequate oxygen delivery. Well, the utilization of oxygen would be impaired in every part of the body, in a mechanism similar to cyanide. And not uncommonly we find cyanide poisoning comes up along with carbon monoxide poisoning because the sources would be similar. And I'm going to mention cyanide poisoning in details in the coming lectures. Clinical presentation. The clinical finding of carbon monoxide poisoning is highly variable and largely non-specific. People who are sleeping or have been drinking alcohol where they were unconscious, if they were exposed to carbon monoxide, they might even die before the development of symptoms. They might come up to the casualty department with sudden death or being dead in his bed, not waking up in the morning. Moderate to mild carbon monoxide intoxication can present with constitutional symptoms. The commonest symptom is headache. Other symptoms like malaise, nausea, lethargy, dizziness, weakness, and vomiting, they all might be present in a moment that people think it's kind of viral illness. Most of the time would be misdiagnosed. Patient might manifest some symptoms ranging from confusion to coma, and this would be due to the affection of the nervous system. Some references were describing the cherry red appearance of the skin and the lips, but this is rather insensitive test and would be expected more with cyanide poisoning. To continue with the clinical presentation, I would mention that cardiac involvement in form of myocardial injury is not uncommon in those patients, and this one would be associated with increased mortality. Myocardial ischemia and ventricular arrhythmias, even pulmonary edema might be evident by the time of the presentation. Severe CO poisoning can produce neurological symptoms, as we mentioned, like seizure or coma. Unfortunately, this one's complication in a delayed manner would be the same as organophosphate. We mentioned that in the past when we had intermediate and delayed syndrome with organophosphate. This one unluckily had the similar thing. And this one, delayed neuropsychiatric syndrome, can arise even after full recovery from carbon monoxide poisoning. But this one's characterized by a variable degree of cognitive dysfunction, personality change, movement disorders, and focal neurological signs. This one generally happens within 20 days of the exposure to carbon monoxide, and these deficits might persist for years and longer. The diagnosis is based on the compatible history: exposure in a family, overnight, heaters, using stove as a heating machine, being in the garage for a while, exposed to that kind of industrial fumes. All of these things might come up with the history, especially in the winter. They come in a larger number than those in summer. Physical examination conjunction with elevated carboxyhemoglobin level measured by carboxyoximetry of arterial blood is enough. Arterial blood gas here is mandatory, but sometimes you can rely on the venous samples as they are accurate enough as the arterial one. Non-smokers might have up to 3% of carboxyhemoglobin in their blood, while smokers might have higher levels, and the shelf or the threshold for the diagnosis would be higher, up to 10 to 15%. Levels above these would be indicative for CO poisoning. The partial pressure of oxygen tends to be normal, as this one reflects the dissolved oxygen inside the blood and is not affected by CO poisoning. In contrast, the hemoglobin that's bind to oxygen, which is oxygen saturation, is profoundly reduced. Once the diagnosis of carbon monoxide intoxication is confirmed, best thing is to do electrocardiograms, and serial ones are indicated especially in severe patients, and cardiac biomarkers might be warranted if patient had some ECG evidences of ischemia, or at least he had some past history of ischemia. CT or head MRI might be helpful to rule out other causes of neurological dysfunction, like associated trauma or neck injury. Hemorrhagic infarction of the globus pallidus, and less frequently the deep white matter, have been reported following acute intoxication. Imaging studies might suggest these abnormalities in the globus pallidus, and these were noted as part of the delayed neurologic syndrome. Management. The half-life of carboxyhemoglobin in the room air is more than 300 minutes, and this should be reduced to a great deal inside the blood through giving high oxygen inhalation, and this was best to be achieved by non-rebreathing masks, not the standard simple mask that you see it in the medical wards. Student who has some medical sessions with me in the past, they know the differences between simple mask and the non-rebreathing masks. You probably need to dig it further and going in the web and find details about the differences of these masks and how do they deliver oxygen in high concentrations. The most important intervention here in CO poisoned patient when he presented to you is removal from the source of CO and then the institution of high oxygen supplementation, because this one going to wash out carbon monoxide from its binding sites on the hemoglobin on the aim to stop that process. Comatose patient or those who have some depression of consciousness in certain ways should be intubated immediately and put on mechanical ventilation to achieve 100% oxygen delivery. For patients suffering from carbon monoxide poisoning after smoke inhalation, it's important, as we emphasized in the past, to consider concomitant cyanide poisoning with carbon monoxide. And this one happens, as I mentioned in the past, simply because the sources would be similar, because cyanide even comes when there is some kind of burning of compound that contain nitrogen and carbon, and especially like when you have some burn, some fire happens in the house, it makes CO and at the same time makes cyanide as well. And both of these might present with a similar clinical picture in fact. Once you had some kind of suspicion of cyanide poisoning, you have to put it into consideration in subsequent treatment. But unluckily, most of the time, doctors try to do an assay for carbon monoxide, And once this diagnosis was confirmed, he would just automatically neglect cyanide as a possibility or the second pathology in the same patient. Many patients might be managed in the emergency department, as most of the symptoms might resolve with simple high flow, high concentration oxygen. Psychiatric assessment is important to assess suicidality of certain patients. The receiving facility of the hospital should have the ability to provide accurate measurements of carbon monoxide levels, ongoing intensive care unit, and hyperbaric oxygen therapy. Now, what's hyperbaric? There is uncertainty around identifying patients who would get benefit from this treatment. However, the delivery of non-hemoglobin bound oxygen to the tissues would be achieved by hyperbaric oxygen. So you're going to pass the oxygen onto the plasma and let it go to the tissues. In this situation with the hyperbaric oxygen, you're not going to rely on hemoglobin to carry oxygen because it cannot offload it to the tissues. That's why in this situation you try to make use of the plasma. The indications are clear and straightforward. CO levels more than 20-25%, CO level more than 20 in a pregnant woman because she has another baby inside the body, loss of consciousness, severe metabolic acidosis like less than 7.1, and evidences of end organ ischemia like ECG evidences or troponins or somewhere else. If hyperbaric oxygen is used, available literature suggests that the benefit would be greatest if it happened in the first 6 hours. No benefit beyond 12 hours. You shouldn't search for a source of hyperbaric oxygen if the timing of the exposure was 12 hours and earlier, because the benefit would be minimal. Anybody who is not meeting the indications for hyperbaric oxygen should be treated with high flow and concentration of oxygen until the percentage of carboxyhemoglobin drops down to less than 5%. How do we have to prevent this? It's a preventable one, although it's a big killer, but it's a preventable and easily preventable one. Be wise in the house. Using those kind of detectors shown in this picture is the best. With the new era of housing in this country, luckily we are using these sensors. Many of them are wireless, they just use batteries. You have to maintain them to make sure that it's working all the time, especially when you are sleeping overnight in a winter season. That's the best thing to work and detect and protect you from any kind of CO poisoning, especially if you're using some kerosene heater in the room or in the house. These detectors are available and they are relatively cheap. Electricity generators should be far away from the houses. Avoid warming up cars inside the garage. That's a bad habit. Although many people like it, but that's bad. House heaters should be maintained, and sometimes alternatives should be avoided, like using the stove as heaters or using firewood inside the rooms to heat up. These would be making a lot of problem. I hope this one helped you and hope to see you in the next lecture.